Today's topic is nursing management for clients with acute respiratory failure. A thorough understanding of the physiologic aspects of the respiratory system is essential for understanding the clinical manifestations, complications, and treatment of acute respiratory failure. This system is important in helping the body meet its needs for oxygenation and tissue perfusion because the source of oxygen for all body cells is the air we breathe. Air with oxygen enters the nose and mouth and moves through the airways or respiratory tubes known as the trachea, bronchi, and bronchioles, and into the air sacs also known as the alveoli of the lungs. Once in the alveoli, the air moves into the blood so that it can be carried to all tissues and organs. The waste gas created in the tissues, known as carbon dioxide, moves from the blood into the alveoli so it can be removed through exhalation. When respiratory failure occurs, there are two problems associated with this gas exchange. Number one, hypoxia, in which inadequate oxygen is being transferred, or number two, hypercarbia, in which the client is retaining too much carbon dioxide. Respiratory failure can be classified as hypoxemia or hypercapnic. The definition of hypoxemia respiratory failure is commonly defined as the partial pressure of arterial oxygen, PaCO2, less than 60 millimeters per mercury when the patient is receiving an inspired oxygen concentration greater than 60%. Disorders such as pneumonia, pulmonary edema, pulmonary emboli, and heart failure are examples of potential alterations that can develop into acute respiratory failure. The primary problem in hypercapnic respiratory failure is insufficient carbon dioxide removal. The client is unable to effectively remove carbon dioxide. Disorders that compromise carbon dioxide removal are drug overdoses with CNS depression like heroin overdoses, neuromuscular diseases, acute asthma, COPD exacerbation, trauma, and higher spinal cord injuries that play a role in respiratory muscle innervation. The respiratory system depends on adequate respiratory movement to exhale carbon dioxide and inhale oxygen. The definition of acute respiratory failure is found in the arterial blood gas, in which the partial pressure of arterial oxygen is less than or equal to 60 millimeters per mercury. The gas exchange has been impaired, which consequently impacts all tissue and organ function. The cause of acute respiratory failure can be due to inflammation, as seen as anaphylaxis, infection, as in pneumonia, inadequate muscle support for ventilation, as seen in neuromuscular diseases such as ALS. It is important to discuss also gerontological considerations of respiratory failure. Older adults have an increased risk of respiratory failure due to reduction in the ventilator capacity, decreased muscle strength, and delayed responses in respiratory rate and depth, in particular in the following of partial pressure of arterial oxygen and partial pressure of arterial carbon dioxide. Clients in acute respiratory failure will present with signs and symptoms of hypoxemia and or hypercarbia. Clients will have a change in level of consciousness by exhibiting restlessness, confusion, anxiety, and or lethargy. Other signs and symptoms include tachycardia due to the lack of oxygen perfusion to tissues and organs, tachypnea if hypoxic, or bradypnea if the client has respiratory depression or ineffective respiratory muscles to exhale carbon dioxide. The client will more likely feel more comfortable sitting upright due to the oxygen demand, such as orthopnea. And lastly, hypertension indicates the body's response to the increased need for oxygenated blood flowing to the tissues. Cyanosis is an unreliable indicator and indicates hypoxemia and is a late sign of respiratory failure. These clinical manifestations that I've just indicated are urgent needs to provide supplemental oxygen support. Respiratory distress without interventions will produce profound changes in clients to include a change from a rapid respiratory rate that slows, suggesting a progression of respiratory muscle fatigue. This increases the probability of respiratory arrest and subsequent cardiac arrhythmias. Signs of deterioration include a tripoding position, inability to speak, a change in the inspiratory to expiratory ratio, muscle retractions and use of accessory muscles like the shoulders. The work of the breathing itself will be harder. Crackles, rhonchi, diminished or absent lung sounds will be present. Bronchial sounds over the lung periphery and a pleural friction rub. Using your assessment skills will be essential to determining early stages of respiratory distress that could lead into respiratory arrest. Laboratory and diagnostic data assist the healthcare team in determining the severity of hypoxemia and the underlying cause. An arterial blood gas determines the pH, partial pressure of arterial oxygen and carbon dioxide, and bicarbonate. This information determines the extent of hypoxemia and the course of action. A chest X-ray is needed to determine the cause of respiratory failure. Also, a complete blood count to determine a potential cause. For example, an elevated white blood cell count could indicate an infection like pneumonia. A comprehensive metabolic panel, otherwise known as CMP, to determine electrolyte imbalances and kidney function. And also a sputum culture will assist in determining the underlying microorganism for antibiotic therapy, in particular if the patient has a productive cough. Blood cultures will also be needed and assist if there is a systemic infection and you're suspecting that some sort of antibiotic therapy would be warranted. And also, lastly, an electrocardiogram, otherwise known as an EKG, if the client has any underlying cardiac issue. The plan for this client is to maintain adequate oxygenation and ventilation. Tissue hypoxia from inadequate oxygenation will ultimately lead to death. The primary intervention is to provide oxygen therapy for any patient who has acute hypoxemia. Mobilization of pulmonary secretions will increase the ability for gas exchange. This includes encouraging the client to cough and deep breathe. Adequate hydration and humidification replaces fluid loss and moisturizes the passageways. You can also do chest physical therapy, which includes 3 interventions: postural suctioning for any postural drainage by cupping the hand and clapping the back. Suctioning, number 2, suctioning for any loose secretions. And lastly, number 3, breathing exercises used, such as use of an insuspirometer or pursed-lip breathing. This may help the client find a more comfortable position that allows easier breathing by sitting up in an upright position. Then, to decrease anxiety that occurs with feeling short of breath, assist the client with relaxation, breathing techniques, and a calming voice. Conserving energy is important for acute respiratory distress. Ambulation is not warranted until the patient has been stabilized. However, ambulation has benefits to mobilize secretions if the patient can tolerate it. Medication therapy can also be included in this, such as bronchodilators to open up the airways, corticosteroids to decrease inflammation, diuretics and or nitroglycerin or opioids to decrease pulmonary congestion as in heart failure, antibiotics for infection and sedation, and analgesics to decrease anxiety, agitation, and pain. These are all specific sort of interventions that can help the patient in acute respiratory failure. If any of these interventions have not improved adequate oxygenation and ventilation, more invasive measures are warranted, such as mechanical ventilation. Positive pressure ventilation may be necessary to include endotracheal intubation and or BiPAP. The overall goals of therapy for the client is adequate oxygenation and ventilation by decreasing the work of breathing, gas exchange improvement with data from an arterial blood gas that is within normal or trending towards normal, breath sounds clear or improving, oxygen saturations equal to or greater than 92 or 93%, and the client can speak in full sentence with returning to baseline functioning. These are all the desired outcomes. This concludes the presentation on nursing management for clients with acute respiratory failure.